Okay, today we will show the examination of the vital signs. Really, the vital signs examination consists of blood pressure measurements, radial pulse assessment, respiratory rate assessment, temperature, and lastly, pulse oximetry. We will show these measurements in sequences. First of all, I'll check the blood pressure. In the blood pressure measurement, the patient should be seated comfortably for at least 5 minutes, and we have to ensure that the patient hadn't taken any cigarette smoking, tea or coffee for at least 30 minutes prior to assessment. Assessment in one side should be followed by assessment of the contralateral side. That's to say, first of all, measure at the right side and then at the left side, taking the highest reading of them. And there may be a difference in the systolic blood pressure of about less than 10 millimeter, which is normal variant, but the highest reading is taken. And those who are younger than 35 years, one should also measure the blood pressure and the legs. And those who are elderly, who had any stigma of autonomic dysfunction or suspect that they are having hypovolemia, the examiner or the candidate should also should measure the blood pressure in the supine position and also in the standing position, searching for postural hypotension. First of all, I'll check the blood pressure on the right side. The sphygmomanometer really at the heart level. I'll ensure, first of all, I'll ensure the place of the brachial pulse. This is the site of the brachial pulse. This is the brachial pulse, and also I'll check for the radial pulse for its patency. Then I'll encircle the sphygmomanometer cuff and I'll raise the blood pressure till the radial pulse becomes impalpable. Now the radial pulse become impalpable. I'll raise the column about 30 millimeter mercury, and then I'll listen via the stethoscope over the right brachial artery. I'll slowly deflate 2 millimeter each time till I get now the first chord cough sound. And to ensure that this is the first chord cough sound and no auscultatory gap, I'll check also again the radial pulse, which should be palpable. Now the radial pulse is palpable, so this is definitely the systolic blood pressure. Then I'll deflate also slowly each time about 2 millimeter. Till the sound is muffled first and then disappear. Now the blood pressure sound is disappear, which correspond to diastolic blood pressure. So the systolic blood pressure was at 130 millimeter mercury and the diastolic blood pressure was 75 millimeter mercury. Blood pressure should also be repeated after a period of about 5 minutes and then repeated at the left side. Highest reading is taken, and after that, if the patient is young, as I said previously, the blood pressure should be taken also at the legs and the upper limb. And if the patient suspect to have autonomic dysfunction, hypovolemia, or is elderly, one should also measure the supine and standing blood pressure. All these issues are about the blood pressure measurements. Okay, regarding the second vital sign is radial pulse assessment. How to check the radial pulse? Really, we had talk about the radial pulse assessment previously in the general examination, but let's repeat a few notes about it. First of all, ensure that the patient hand is slightly supinated and flexed at the wrist using 3 fingers. The first two is to press over the radial side, and the third finger, the left index, is to check the pulse, and you can count the pulse for about quarter minute and then multiply the result by 4 to get a full minute. Really, now we had 15 beats per minute by 4, so it is 60 beats per minute. The volume should also be checked, whether it is good volume, low volume, or large volume of the pulse. The rhythm also should also be taken from here, and the comment will be either regular or irregular. If it is irregular, you have to comment that the irregularity is continuous, that's to say irregularly irregular, or it is just on occasion, that's to say regular irregularity, which occur in bigeminy and trigeminy. After that, really, you have to check for the collapsing pulse in the following maneuver. We had already checked the radial pulse with the left hand. Now I'll use the right hand using this part of the palm, encircling the radial artery just like this, and I'll grasp the hand and immediately elevate the hand up. Okay, what do you feel to say that this is a collapsing pulse? Really, you will feel that a large volume of pulse. Quickly press this part and then quickly collapsed. Quickly distend this part and then quickly collapse. If you feel this, collapsing pulse is present. After that, really, you have to check for radial delay or radial inequality. You will check both radial artery just like this, and to ensure that both radial pulse occurs concomitantly. Yes, they are concomitant. After that, you have to check for the radiofemoral delay. You have to check for the femoral artery. Here, as we said, it is mid-inguinal and should be concomitant with that of the radial artery. After that, really, you have to get an impression about the status of the vessel wall, whether they are elastic and soft or whether they are rigid and hard. After that, really, if the pulse rhythm is irregularly irregular, you have to check for the pulse deficit. How can we make this measurement? Really, by checking the heart rate of the mitral area. Also, for 1 minute, this measurement should be taken for 1 minute. And here, the heart rate in case of atrial fibrillation with the resultant irregularity, the heart rate will be higher than the pulse rate. Really, I'll omit to complete 1 minute because the patient had regular rhythm, but in case of irregular rhythm, you have to complete for full minutes, and then to subtract the radial pulse rate from the heart rate. The heart rate is higher than the pulse rate, and to see how much is the pulse deficit, for example, 20 beats per minute, 30 beats per minute, and so on. In reality, when you check the radial pulse, you have to have an idea about the character of the pulse. Really, the best artery which give you the character of the pulse is the carotid artery. But here, one can really estimate or can get an impression about the pulsus bigeminus, about pulsus alternans. Really, in pulsus bigeminus, as we know, each ectopic beat will be followed by compensatory pause and then the normal beat. The normal beat will have larger stroke volume because the contraction at the ectopic beat is inefficient, and for this reason the already existed blood with the normal blood of the normal bead will be ejected. So we will get an impression of large bead, and a strong bead, and of that of weak bead. This occurs in pulsus bigeminus. What's about the pulsus alternans? Pulsus alternans really occur in patients with advanced left-sided heart failure, and sometimes after ventricular tachycardia and after frequent ectopic beats. This occur and give an impression to the examiner, to the candidate, that the radial pulse also had normal beat and some beat which is weak. This is really difficult to ascertain its presence, but we have a maneuver for its presence. How can we do this maneuver? This maneuver in reality is done with the use of sphygmomanometer. Also with the sphygmomanometer. First of all, I'll check at the systolic blood pressure. When you check the systolic blood pressure, I'll inflate the cuff till the radial pulse also became impalpable as we performed in the blood pressure assessment, and then I'll raise it as we have learned to 130. I'll slow till I hear the systolic blood pressure. Now I hear the first Korotkoff sound, the systolic blood pressure, just a few millimeter lower it, few millimeter. You will hear just here, for example, if you have just to lower few millimeter, you will hear that there is apparent doubling of the beat of the Korotkoff sounds. That's to say, at the systolic blood pressure, at the normal systolic blood pressure, only the strong beat will be heard, while the weak beat cannot be, or it is difficult to be heard. If you lower the systolic blood pressure just a few millimeter, you will hear the strong beat and the weak beat. Or sometimes, once you get the systolic blood pressure, listen to the Korotkoff sound, the systolic blood pressure sound, you will hear strong beat and then weak beat. This is really called pulsus alternans, and it is a characteristic of severe LV dysfunction. As we said, it's sometimes occur in patients with V2 or following ectopic beat. Another maneuver in reality the examination committee may ask about is the what we call it pulsus paradoxus. Pulsus paradoxus also performed with the blood pressure. First of all, I'll check the systolic blood pressure in the expiration, and then I'll check it at the time of inspiration. In the normal state, really, the patient can breathe in relaxed state. You should ask him that he or she exhale his or her breath while you check for systolic blood pressure, and then to get full inspiration while you also check the blood pressure, lower it down and see the difference between first the expiration level and then the inspiration level, and see how much. Normally it is about 10 millimeter mercury. If it is more than this, if the difference is more than this, one can expect that exaggerated pulsus paradoxus is present, as I'll show to you. First of all, I'll check the systolic blood pressure, and I'll ask the patient to exhale his breathing. As we know, I know the systolic blood pressure of this patient, and I'll ask him to expire, to exhale breathe. حماده بس اريد منك تطلع النفس كالآتي. منه شيك واقول لك هاي. اوكي يلا. عشتي الفكرة. Okay. Then I'll ask the patient up to this level I had detected, and then I'll ask the patient to take full inspiration. هسه أريدك تأخذ نفس، أخذ نفس، خذ نفس على كيفك هيك مثلي. أوكي يلا. هاي هي عشتك. About 9 millimeter the difference. هاي هي عشتك. Okay. The difference between expiratory level and inspiratory level is a normal phenomenon. We call it pulsus paradoxus. But any exaggeration of this normal status is called exaggerated pulsus paradoxus, and it is a characteristic of respiratory disease, for example, asthma, and also may occur in patients with pericardial effusion, severe pericardial effusion, and patient with pericardial tamponade. Okay, regarding the examination of the vital sign, what is removed from is the first of all, or the third one is the respiratory rate, the temperature, and lastly the pulse oximetry. In the assessment of the respiratory rate, you have to make the patient think that you are going to check his pulse while you are looking at his chest, and to see how many times the chest is recoil, and which indicates the respiratory rate, which is normally from 14 up to 18, and sometimes it is lesser than this. If the patient had the respiratory for full minute, you have to check it. If the patient had lesser than this range, this is what we call it brady. If the patient had more than this range, that's to say up to more than 18 and more than 20, this is what we call it tachypnea. If the patient had lower than this range, lesser than 12, some suggest 10, we call it bradypnea. And a patient who had complete cessation of breathing, we call it apnea, and we have to know about the causes of that. After that, we have to check the temperature of the patient. Really, you have to know the normal temperature of the patient, which is 36.4 up to 37.2, and you have to know that there is daily normal variation of about 0.4 to 0.5 from early morning into the 4 or 6 p.m. and this is normal variation. And you have to know that the core body temperature, or the real actual body temperature, is the rectal temperature, which is 0.5 higher than the oral temperature, and that of the axilla or groin is about 0.5 centigrade lower than the oral temperature. Really, we have many methods or many ways in which we can measure the body temperature. First of all is the oral temperature. We have external auditory, we have the forehead, axilla, groin, or even the rectal method. And each way is chosen according to the clinical status of the patient and his age. For example, if the patient is comatose, you cannot check his oral temperature. Instead, you can use his axillary temperature, corrected axillary temperature, or even the rectal temperature. In a patient who is younger than 5 years of old, we usually choose the corrected axillary temperature, while those who are, for example, we would like to check his exact body temperature, we check his rectal body temperature. All these issues are about the body temperature. We have to put also another issue in our mind, that the body temperature, if it is increased 1 centigrade, there will be 10 beats increment in the pulse. Absence of this increase with the elevation of the body temperature, we call it relative bradycardia, or pulse temperature dissociation. I had many causes in the form of, for example, typhoid, brucellosis, drugs, and so on. You have to check about them. Lastly, we have to check for the pulse oximetry using pulse oximeter. This is the pulse oximeter, and I'll check the patient left index. First of all, you have to choose 2 or more than this areas, and we will see here the saturation of the oxygen. Saturation of the oxygen of our volunteer is 99. Is 99. This is the 99, and this is the pulse rate, which is 90. And then you have to check the contralateral side. Also, it is calculating now. it is also 99, and the pulse rate, this is now it is 100, and the pulse rate is 92. And we have to know that the pulse oximetry can detect hypoxia before the patient become cyanosis. And we have many sentences in which the pulse oximeter is not accurate. For example, if the patient had hypothermia or severe vasoconstriction, or the patient have cardiogenic shock, hypovolemic shock, this will not be function. On the other hand, if the patient had severe tricuspid regurgitation, this device will signal the venous instead of capillary signal. Really, this device, pulse oximeter, will detect the saturation of oxygen inside the blood. The saturation, not the partial pressure or the tension. The tension or the partial pressure of oxygen is detected via a sampling from an arterial site. Really, we have additional 3 issues the candidates should know about them. These issues are patient with methemoglobinemia. The pulse oximeter will be falsely lower than the normal. It detects the saturation of oxygen to about 85, the saturation percentage of oxygen saturation, which is not wrong, while the arterial tension, oxygen tension, will be normal. Patient with carboxyhemoglobinemia, the pulse oximeter is also misleading, in which the saturation of oxygen will be higher than normal, approaches 100, while the tension of the oxygen from the arterial side will be normal. The third and the last issue is a patient with very high white blood cell count, immature cells. Those patients will have the normal saturation of oxygen, while the oxygen tension inside their blood will be low. In this state, the patient with very high white blood cell count, the saturation of oxygen via pulse oximeter will be more accurate than the blood because of the consumption of the oxygen.